confidence you can have. But in lupus, I think the disease dictates terms a lot more. The disease is really made up its mind that it's going to wreak havoc, means it will do that, whatever you do, irrespective of what you do. But if the disease sometimes has a mild way of presentation and mild way of going on, it will actually go on that way. So I think it's got a lot to do with the disease. Disease is the king here. Let's try to understand SLE in total. So when you think of SLE, so I told you, any disease in rheumatology that you think about, we have to bring in this genetic and environmental factors, and together they are responsible for a central key event, and that will lead on to the production of a central key pathogenic cytokine. That is how the whole disease spectrizes. Before we look into that, this famous 9:1 ratio, the females more than males 9:1 ratio, this is classical, but we have now understood that there's an entity called childhood SLE, and now we are also having a postmenopausal SLE. Previously, we were not talking about this so much. Childhood SLE and postmenopausal SLE. Childhood SLE, please keep in mind that there is 100% renal involvement. That's a stock question that you get, because adult SLE is 40% renal involvement, here is 100%. Postmenopausal, etc., you have a milder form of SLE. Okay, and there is almost a classical renal sparing. So milder form of SLE, renal sparing. So here we'll be using the word renal again and again, because the main issue in lupus is lupus nephritis. You were asked what is the most common cause of death in RA, you can confidently say accelerated atherosclerosis leading to ACS. But when you're asked what is the most common cause of death in SLE, in the first 5 years of SLE, accelerated atherosclerosis is not responsible. It is infection by lupus nephritis, of which Indian data is more of infections. Okay, later on, after the first 5 to 10 years, it is more of accelerated atherosclerosis, MI. So this is about childhood and postmenopausal. It's telling you that is also there. Male SLE is also there, but male SLE has even more poor prognosis. It is more severe. So childhood is 100% renal, male is more severe, postmenopausal is more milder because there is renal sparing. Correct? The opening points to keep in mind, and very, very strong family history. RA family history is important, but not to this extent. Here it is like definitely you will find out somebody. Mother, sister, mother's elder sister, younger sister, grandmother, somebody will be there. Okay, that's how this is. Genetic and environmental factors, when you try to look into, very important to keep in mind that we have HLA and we have non-HLA. So HLA is there, non-HLA is there. In genetics, the most important thing is C1q deficiency. So C1q deficiency, then C2 and C4 deficiency. Early complement deficiencies are very, very, very important. Late complement deficiencies predispose you to ACD infections. Early complement deficiencies will predispose you to SLE. So C1q deficiency, which is actually a non-HLA. C2, C4 are part of HLA class 3. So you can put it under HLA. So whichever way you want. C1q deficiency, C2, C4 deficiency. Second thing is the TREX gene on chromosome 3. TREX gene on chromosome 3. And then we have a lot of genes on the X chromosome. So that's why having an additional X chromosome puts you at more risk for SLE. Klinefelter has much more SLE than Downs. And Turners. So that's the reason, because X chromosome is very closely linked to this, and we have a lot of genes on the X chromosome also. So out of this HLA, non-HLA thing, C1q deficiency is very, very, very important. And HLA DR2, DR3, HLA DR2, DR3. Again, very important. So there it was DR4 in RA, here DR2, DR3, and single most important there was equal to Vikram motif. Here the most important thing is C1q deficiency or early complement deficiency. Environmental factors, if you look at RA, smoking was the single most important environmental factors. Here anything and everything to do with estrogen is the single most important environmental factor, including OCPs, HRP and all those things. Also associated is EBV, also associated is UVB rays. So estrogen is there, UVB rays is there, EBV is there, but estrogen is the single most important thing. There the single most important thing was smoking. So I think the comparison is very clear. Together, what do they do? Here the issue is, this is more to do with your innate immune mechanism. RA has got a lot to do with your adaptive immune system. This has got a lot to do with your innate immune mechanism. What actually happens is defective clearance of apoptotic debris. In very simple terms, these genetic and environmental factors are together responsible for a state where apoptotic debris is not effectively cleared. I can even call it as an immune dysregulation proper. There is an immune dysregulation, or you can even say loss of self-tolerance, where there is an inability to clear this apoptotic debris. Neutrophils kill by netosis. Neutrophils can do phagocytosis as well as netosis. Even after netosis, this debris is not effectively clear. So we are having defective clearance of debris basically. Whenever you are having defective clearance of debris, antibodies are actually formed against this. Those antibodies are responsible for formation of immune complexes, and that is why SLE is called as an immune complex mediated disease or a type 3 hypersensitivity. Immune complexes get deposited in the vessel. Immune complexes get deposited at sites where the blood is being filtered to form some other fluid. So synovium, where blood is filtered from the synovial fluid, so that's why it can produce synovitis. Glomerular blood is filtered from the urine, so you can get glomerular nephritis. It vasculitis. So that is how the disease will be. Okay, so on the whole, if you try to see what is the problem in RA, it was all about abnormal protein modification. What is the problem in SLE? It is all defective clearance of apoptotic debris or necrotic debris. Necrotic debris means neutrophil will try to kill. By actin polymerization, what it will do is it will release the decondensed chromatin outside. And by releasing the decondensed chromatin outside, it will form a trap around the antigen because this decondensed chromatin will be coated with microvesical products. This is called netosis. Netosis is a very important mode of killing, okay, which you study in pathology. Now, this netotic debris, so neutrophil will kill by killing itself rather. So, this debris has to be cleared off, which is not being done in SLE. Okay. So this is about the immune mechanics and what happens. If you studied RA and you have got a pattern set, it's much more easier. Now, once you are having this immune complexes, so antigen antibody complexes, immune complexes, everything I told you. But defective clearance of netotic debris cannot straight away form immune complexes, right? There has to be something in the middle because the cytokine has to be involved. Whenever there is a defective clearance of defective clearance of your apoptotic debris, innate immune system will naturally be activated. Innate immune system is going to produce a single most important central cytokine here. In RA it was TNF alpha, here it is interferon alpha, and interferon alpha is produced by your plasmacytoid dendritic cells. So plasmacytoid dendritic cells will produce interferon alpha. Macrophages produce TNF alpha. This interferon alpha, so you have to keep in mind when you study immunology. This interferon alpha will cause a very, very abundant activation of T cells. Okay, extreme cytokine storm-like kind of activation of T cells. These T cells can actually be activated along Th1, Th2, etc. so many ways. But here, Th2 is more predominant. Th17 is there, but Th2 is more predominant. In RA, it was Th1. So this Th2 predominance is again very, very important because it is this Th2 that is responsible for forming interleukin 4, interleukin 5, and interleukin 13, of which interleukin 4 will secondarily activate the B cells, and the B cells will produce antibodies. So T cell activating B cell here is very important. One very important mechanism by which T cell activates the B cell is by forming interleukin 4. Okay, so interferons are there by plasmacytoid dendritic cells. T cells are actually getting activated along the Th2 lineage. Th2 lineage is forming interleukin 4. That brings us to a very important question. What are the three mechanisms by which your T cell can secondarily activate the B cell? T cells can secondarily activate the B cell by one, interleukin 4, second by CD40 ligand CD40 interaction. CD40 ligand on the T cells. On the B cell and interleukin 12-21 cascade. So interleukin 12-21 cascade, 40 ligand 40 interaction, interleukin 4. These are the three mechanisms by which T cells can secondarily activate the B cell. Again, immunologist, which will study in pathology. Okay, so these many things are there. Clear? Once this is set, then we have to start going into the disease proper. Before we go to the disease proper, every time you are thinking of SLE, what comes to your mind? ANA comes to your mind because ANA is a window through which you see this connective tissue diseases, this whole spectrum of connective tissue diseases. You actually see through this window called ANA. What is the meaning of that? Let me tell you, 97% of patients with SLE are ANA positive. So 97% of patients with SLE are ANA positive. In different rheumatology conditions, you have different numbers. Scleroderma 95, polymyositis 93, different numbers are there. Least is for Sjogren. In Sjogren only 85% people are ANA positive. So 85% people are ANA positive. What am I trying to actually tell you out of this? What am I trying to tell you out of this? One very important MCQ question. Is there any condition where 100% of the people are ANA positive? There are three conditions in rheumatology where every single person is ANA positive. One is drug-induced lupus erythematosus, which we will see. Second one is type 1 autoimmune hepatitis. And third one is mixed connective tissue disease. These are the three conditions where every single patient is ANA positive. So that is one MCQ. And Jogren has least ANA positivity among CTD, second MCQ. And in SLE, 97% are ANA positive. So what is the meaning of this? The meaning of this is when you think of a multi-system CTD, when you think of a multi-system CTD, except RA, this is very important, okay? RA and ANA have nothing to do with each other. In RA, rheumatoid arthritis, in that discussion, I never mentioned the word ANA itself. In RA, if you get ANA, you tear the report and put it in the basket. RA, fibromyalgia, psoriasis, there are some conditions where you will get ANA like that, which has no value. So don't think about it. Generally, as far as other multi-system CTDs are concerned, that means if ANA is positive, we will take the discussion forward. If ANA is negative, okay, we'll forget about it. That is a general dictum that we use. But again, I'm saying that's not a 100% foolproof dictum because there can be some exceptions. So if your ANA is positive, then you will think about CTD. If ANA is negative, generally you don't think of CTD. That's the Mbbs understanding, but PG understanding will change.
ANA positive, CTD. ANA negative, not CTD.
So a general dictum that we use. But again, I'm saying that's not a 100% foolproof dictum because there can be some exceptions. So if your ANA is positive, then you will think about CTD. If ANA is negative, generally you don't think of CTD. That's the Mbbs understanding, but PG understanding will change. So ANA is a screening test for CTDs in general, not for SLE or anything. It is a CTD screening test, connective tissue disease screening test. Okay, so that is clear. So when that is clear, let us try to get into the crux of it. What ANA? You cannot just keep saying ANA. You have to be saying ANA by indirect immunofluorescence. That is very, very important because ANA by ELISA right now has no value. So ANA has to be done by indirect immunofluorescence. The titer has to be more than 1 in 5, 10, very, very important because 1 in 5, 10, 20, etc. can be seen in normal people with fever, etc. It can be seen. So titer has to be more than 1 in 80 and it has to be done using the human epithelial 2 cell line. F2 cell line, indirect immunofluorescence titer has to be more than 1 in 80. This is what we consider as a positive ANA result. Okay, this is what we consider as a positive ANA result. And ANA, I'm telling you, is a screening test for what? Screening test for CTD. Okay, so once this is there, then I want to know the pattern. This pattern is very important. I have to know the pattern. Pattern can be homogeneous pattern, DFS pattern, fine speckled pattern, coarse speckled pattern, nucleolar pattern, and lastly cytoplasmic pattern. So you have to be knowing just one word about this, but last time this was asked. Homogeneous pattern means the antibody can be either dsDNA or it can be antihistone. So two things can be possible. dsDNA can be possible, antihistone can be possible. That we need to do the ANA profile to find it out naturally, that we'll do. But homogeneous means dsDNA and antihistone are the two antibodies possible. dsDNA is actually speaking a specific antibody for SLE, and antihistone is an antibody for drug-induced lupus erythematosus. So these two things are possible. Dense fine speckled is a new entity in the list. Dense fine speckled means that it rules out the CTD. Very, very important. Dense fine speckled pattern means that is against the diagnosis of a connective tissue disease. It rules out the CTD. Fine speckled pattern means that you are mostly having SSA or SSB.
Dense fine speckled. No CTD.
SSA, SSB, what you see in Jogren syndrome. Coarse speckled means that it's mostly going to be anti-Smith antibody, which is again seen in SLE, or it can be seen with anti-U1RP, which is seen in mixed connective tissue disease. So U1RP very important, is seen in MCTD. Coarse speckled can be anti-Smith, which is seen in SLE. Nucleolar pattern is seen in PMSCL70. What is PMSCL70? Polymyositis scleroderma overlap. It's a kind of a syndrome with polymyositis scleroderma overlap, which is called PMSCL70. That is where you see nucleolar pattern, again asked in IMS. Okay, cytoplasm is for anti-Jo1 antibody. This cytoplasmic pattern. Anti-Jo1 antibody is seen as polymyositis dermatomyositis, which we have discussed so many number of times. Okay, and we'll again see. So polymyositis dermatomyositis, we can have this anti-synthetase syndrome. This anti-synthetase syndrome is characterized by anti-Jo1 antibody, where you get Raynaud's, mechanic scan, ILD, arthritis, and so many things that we'll see. So cytoplasmic is anti-Jo1, nucleolar is anti-PMSCL70, coarse speckled is anti-Smith or anti-1RP, fine speckled is mostly Jogren. DFS pattern rules out CTD, homogeneous pattern can be touched, dsDNA or antihistone. This is what you understand out of ANA. Now please keep in mind that you are thinking of SLE and ANA has come as negative. So when you are thinking of SLE, you are thinking of SLE but ANA has come as negative. In that case, there's a chance like 3% of people can have ANA negativity. Only 97% have ANA positive. Some books say 98%, but generally we go with Kelly 97%. So then, is it possible? Yes, it is possible. So you have to do the ANA profile. So otherwise also you must do ANA profile, but if you are in serious doubt, you have to do the ANA profile. ANA profile is done by immunoblot. Okay, so there are two profiles here. I'll just show you that. One is called the ENA profile and the other one is called the ANA profile. We don't do ENA profile because you get hardly only 6 antibodies. But in ANA profile, we get all the antibodies. Almost 14 antibodies we get in the ANA profile. ANA profile is done by immunoblot. So ANA profile you do. And it is extremely important to keep this in mind. Why this is so important to keep in mind is that's ANA profile. But in ANA profile,
anti-Smith, anti-Stone, anti-DSDNA, anti-Dow, anti-La, anti-ribosomal P protein. Oh,
we get all the antibodies. See, almost 14 antibodies we get in the ANA profile. ANA profile is done by immunoblot. So ANA profile. And it is extremely important to keep this in mind. Why this is so important to keep in mind is that ANA profile we are doing in a patient whom we suspect of SLE, but ANA is negative, but still we are doing. To look for a very important antibody called anti-ROLA. Because anti-ROLA is positive in a set of patients who are actually having this ANA negative lupus. So whenever you are having ANA negative lupus, look for anti-ROLA, of which La is not significant these days because La is positive only when Rho is positive. So that is why anti-Rho is most important. Best called as anti-Rho W52 or SSA. Okay, so I think that part is very, very clear. So when you are doing ANA, you are looking for it as a screening test to open up the window of connective tissue diseases, and based on the pattern, you get more ideas also. So ANA negative is what we are actually talking about. Clear? So I think that basic intro part to SLE is now very, very clear. How do you take it forward? So I told you ANA is positive means we have to definitely do the ANA profile. Generally, if ANA negative, we stop with that. But if ANA is positive, we have to do the ANA profile and look for the antibodies inside that. And when ANA is positive, what all you need to know? You need to know the titer, you need to know whether it is done by indirect immunofluorescence, and you need to know the pattern. These many things are there. Let us look into the ANA profile. In the ANA profile, first thing that you will be looking for will be dsDNA and Smith. You look for anti-dsDNA antibody and you look for anti-Smith antibody because they are very, very specific for SLE. So you'll naturally be looking for them. They are very specific for SLE. Of which theoretically speaking, anti-Smith is more specific. So theoretically speaking, anti-Smith is more specific. But even though anti-Smith is theoretically speaking more specific than anti-dsDNA, we think anti-dsDNA has more value because we can measure the titers by ELISA separately. So when you measure the titers by ELISA, that correlates with increased risk for nephritis and vasculitis. So that is one reason why dsDNA is preferred. Second, dsDNA is positive in around 75% of patients with SLE, whereas anti-Smith is positive only in around 25% of SLE. So 75% have dsDNA positivity, only 25% have Smith positivity. So because of these two reasons, out of the two, I am more happy with dsDNA. And SLE is a disease which keeps on relapsing, right? So when it keeps on relapsing, dsDNA titers can be used to assess disease activity. Then comes anti-ROLA. Okay, then comes anti-ROLA. Anti-ROLA is a very, very important discussion. So when the SLE patient has anti-ROLA positivity, or even you say anti-RO positivity, what does it mean? SLE positive patient having anti-RO positivity, first thing you know is that this patient has secondary Sjogren. And secondary Sjogren is most commonly due to RA, then due to SLE. Second thing that you know when you are having anti-ROLA positivity is pregnancy, the positivity of anti-ROLA may be a risk for neonatal lupus with complete heart block. So pregnancy having anti-ROLA, you can have neonatal lupus with complete heart block. Third, anti-ROLA is associated with better prognosis in SLE, very, very important, because it decreases the risk for nephritis vasculitis. Correct, decreases the risk for nephritis vasculitis. Anti-dsDNA increases the risk for nephritis vasculitis, anti-ROLA decreases the risk for nephritis vasculitis. Fourth thing is that a very important skin lesion is associated with anti-ROLA. That is called, that we see, subacute cutaneous lupus. Okay, that is called subacute cutaneous lupus. So skin lesion associated with anti-ROLA is subacute cutaneous lupus. 5, anti-ROLA is associated with shrinking lung syndrome. Okay, that is not due to lung shrinking or anything, it's due to diaphragmatic palsy. So these are the points in antirola. Secondary Sjogren, pregnancy, better prognosis, subacute cutaneous lupus, shrinking lung syndrome. And always remember, ANA negative lupus is an entity that you can identify by the presence of which antibody? Antirola. Okay, elderly, we are having this category itself now, postmenopausal who are ANA negative but are having antirola lupus. So that antibody is also very clear. What are the other antibodies that you have to be knowing? One is the anti-phospholipid syndrome associated antibodies, which are a separate entity altogether. Then you have the anti-RBC antibody, which is responsible for PAM antibody autoimmune hemolytic anemia. Very, very important, which is IgG. APS is important to know because 1/3 of patients with SLE have APS. 1/3 of patients with SLE have APS. Third, you can have anti-platelet antibodies. And anti-platelet antibodies in SLE are responsible for secondary ITP. Anti-platelet antibodies in SLE are responsible for secondary ITP. Correct. 4, you have anti-glutamate antibodies. Anti-glutamate antibodies, which are also called anti-neuronal antibodies. They are the most common antibodies in CNS lupus. And the most common manifestation of the CNS lupus is cognitive dysfunction. So most common antibodies, anti-neuronal antibody, and most common manifestation is cognitive dysfunction. 5 is anti-ribosomal P antibody. Exam question, anti-ribosomal P antibody is associated with psychosis bar depression in CNS lupus. So that is associated with psychosis bar depression in CNS lupus. So these many things are the other antibodies. So we have discussed the entire spectrum of antibodies now. Each of the antibodies there are questions. So first you do ANA, then you do the ANA profile. And in ANA you look for the titers, you look for the patterns. And you also look for whether it is done by indirect immunofluorescence. And correspondingly you do the profile, and in the profile you get a much better idea. Okay, also to keep in mind that SLE may be part of an overlap syndrome. So overlap means you are having features of more than one out of the 6 CTDs. What are more than one out of the 6 CTDs? SLE is there, Sjogren is there, polymyositis, dermatomyositis, systemic sclerosis, rheumatoid arthritis. So 3, 4, 5, 6. When you are having features of more than one out of the CTDs, then we call it as overlap syndrome. Correct. This Sjogren is the most common in an overlap. Okay. This overlap with anti-U1 RNP. So overlap with anti-U1 RNP and ANA positive in 100%. ANA positive in 100%. Anti-U1 RNP. Female-male ratio is 15:1. This is called as MCTD. So any overlap which is very specific type of overlap, that's what it means. A specific type of overlap with anti-U1 RNP positivity, ANA positive 100%, MCTD, female more than male 15:1 is MCTD. And always remember, in MCTD we get very severe Raynaud's phenomena. So very severe Raynaud's phenomena is the catch point, which you'll again see. Fissuring and all will be seen there. So when you get that kind of question, that's when MCTD can. Like we see in scleroderma. Okay, so these many antibodies, everything is very clear now. So when you start talking about SLE from a clinical angle, okay, when you start talking about SLE from a clinical angle, there are 2 things which I forgot to do. What are the 2 things I forgot to do? One, ANA should never be repeated. Repeating RF and CCP is no value. Similarly, repeating ANA is no value. ANA is to be done only at the time of diagnosis. Second, what are the things that correlate with disease activity in SLE? One, I told you dsDNA titers score. That's why to specifically look for dsDNA titers by ELISA is very important. Second is low complements, decrease C3, decrease C4, they again correlate to activity in SLE. That is again very important to know. And keeping in mind that ESR will be high, CRP will be low in SLE. So low CRP, low C3, C4, dsDNA titers. Why CRP is low in SLE? So many theories are there. Interferon alpha seems to suppress CRP is one theory. Anti-CRP antibodies are seen in SLE is another theory. Whatever. CRP is low, ESR is high, low C3, C4, high dsDNA titers. Okay, so that is about the immunology of SLE. From the immunology of SLE, we come to the system manifestations of SLE. So we have to compare it with RA in a head-to-foot fashion that we'll do. Before that, to know that constitutional symptoms are seen in 90 to 95% of patients. This is very, very important to know. RA to get constitutional symptoms is very, very unlikely, very uncommon. But here, fever can be there. So PU SLE can be a DD. Fever with thrombocytopenia or fever with leukopenia, it can be actually DD. Fatigue and weight loss, it can be a DD. So that you have to be very, very careful. And the two most important symptoms are one, mucocutaneous involvement, and two, musculoskeletal. Both are 80 to 90%. This is from Kelly to tell you that there is nothing that is more. Many people ask me skin more involved or joint more involved. Actually, both are the same, 80 to 90%. What is most striking is constitutional symptoms. Correct. It's very, very clear. Let us start off with the musculoskeletal and mucocutaneous manifestations. As far as musculoskeletal manifestations in SLE are concerned, I don't have to tell you because we discussed. It is exactly like chronic multisystem, inflammatory, polyarthritis, small joints, upper limb, bilateral. The most important point is that it is non-erosive, but it can be deforming. Deformities are present due to laxity of ligament. That's the most important point, and this is called checkout arthropathy. First described in acute rheumatic fever. So this is very, very clear. Then comes the mucocutaneous manifestations. Mucocutaneous manifestations represents what we call as the many phases of lupus. As far as mucocutaneous manifestations in SLE are concerned, let us try to put it as lupus-specific lesions and lupus-non-specific lesions. So lupus-specific lesions and lupus-non-specific lesions.
I think it's an end now. Okay, let's finish this.
Is how the conventional classification itself is. So, when you think of lupus-specific lesions, that is what you should be studying. Lupus-specific lesions include acute cutaneous lupus erythematosus. Acute cutaneous lupus erythematosus. This is called as ACLE. ACLE. Then we have subacute cutaneous lupus erythematosus. The subacute cutaneous lupus erythematosus is called SCLE. Then we have chronic cutaneous lupus erythematosus. Chronic cutaneous lupus erythematosus is called CCLE. So we have ACLE, we have SCLE, and we have CCLE. So when you talk about ACLE, the most common pattern of ACLE is this one. This is called as a malar rash. Okay. This is extremely photosensitive rash. That's the first point. It is the most common rash. It is an erythematous rash. So highly erythematous, most common photosensitive rash. So erythematous photosensitive rash is a malar rash. It is the most common type of rash, which has a tendency for scaling, plus or minus scaling, but it is a non-scarring rash. So it is a non-scarring rash, may be associated with non-scarring alopecia and also associated with oral ulcers. Typically, you see ulcers on the hard palate. So hard palate ulcers, non-scarring alopecia, non-scarring ulcer, non-scarring rash, scaling plus or minus is photosensitive. And it generally tends to...
I think it's an end now. We have to stop the stream. 28 minutes. And here we go.